what's the amount, or you won't encourage doctors to put some very thin layer of HA? Because I see that your colleagues put some bumpy HA over there and surrounded by fibrosis, which will be a disaster for patient. But if you choose some proper fillers, will be the red line will be not strict for practitioners. So I'm wondering what's your comment?
There's no hard and fast rule when you should stop, but then there are some guidelines because these all of kind of guidelines we learn from our painful mistakes. For instance, where you have patients with very creepy and thin skin, where almost you can see food. This is the patients that you should stay away from fillers.
Yes.
Or you have patients, group of patients that have a very, very dense adhesion of the superficial skin immediately into the bone. There's virtually no muscle there, no soft tissue there. Then this is patient, perhaps you just want to release a little bit of the adhesion without injecting any product there, because even you inject product with good result, you will end up with Kindle effect.
Yes.
Yeah, because polynucleotides, I think it's more repair. There's component that is stimulate fibroblast activities, but I haven't. So till now, I think polynucleotides and PDRN has been used, and there hasn't any reports about nodular formation. I know there are some countries who are now using polynucleotides as a teaching method to teach people to do injection in terms of fillers. So the worst case scenario is no improvements. You won't have any sort of problems, even though it's intravascular injection. So in that sense, I think there is some sort of truth behind it. But like you say, yes, if there are some residual fillers, there might be some immune sort of reaction that might happen. But from what we have understand from the basic research was that
So I think this one is more challenging case. So, and this anatomy that I think all of you guys know about this one. I'm gonna run through the anatomy a little bit before going to the case. This one we call orbicularis ligament. On the middle part we call T-top ligament, and we have zygomatic ligament, and extension to the anterior part we call zygomatic cutaneous ligament. And here the problem about under the eyes, like this one is the area of the eye bag, and here we have orbicularis ligament, and this area under the palpebral malar group. The orbicularis ligament we have here, and here is a layer of orbicularis oculi muscle, and underneath it there is a deep fat. Here is sub or suborbicularis oculi fat, and under this one is zygomatic cutaneous ligament. The inferior to this area, I mean the deep fat, is a deep medial sheath fat. So when we have the problem about, usually under the eye we have the groove like this one and this one. So this is the anatomy, the eye globe, and this one is lower lid and the upper lid. And when we are young, the bone supporting is good and the skin is still tight, and this is the fat, and this here the orbicularis is still tight. Together with orbital septum is still tight and keep the fat behind the orbital septum. But when we age, we lost the bone, we have the bone resorption, we lost the deep fat, and the skin got laxity, and also the orbicularis and orbital septum. So you have the eye bag because of the fat prolapse.
Submissions, and if you can, for one particular issues, so it's a sciatica issues. So we're going to have all the papers that for that volume is sciatica. So you can divide it into energy-based devices, fillers, and neuromodulators, and so on and so forth. And for so much what you've been done, it's not just one volume. You might have 2 or 3 consecutive.
I strongly agree.
you can do that, because a lot of people doing that. Stephen Diane and also Sabina Frappet, they're using, they're doing it. They've been traveling around the world and doing diversity in beauty and so on. They're going to publish, and I'm getting involved as well. So they gather all the talent together and get it organized, and so that you can pass the message very clearly and more